Hello, I'm Esme Fuller-Thompson. I'm the director of the Institute for Life Course and Aging at the University of Toronto. We are so delighted today to have Dr. Irina Nica-Graham with us. Dr. Nica-Graham is a geriatric psychiatrist at Mount Sinai Hospital, and she's also an assistant professor in the Department of Psychiatry at the University of Toronto. Thank you so much for joining us today.
You're welcome. Thank you for having me back.
Well, we have lots of questions. So first off, what is depression and how do you differentiate it from just feeling blue occasionally, particularly in the context of this pandemic?
Being sad, feeling blue are normal feelings, and we all experience them. If someone is experiencing more illness or grief or social isolation, especially in times of difficulty like we're experiencing now, it's I think normal, and they can expect to feel sad and blue. But when these feelings persist, if they're there for weeks and weeks, if they're unable to shake them off, to find pleasure in other things, to accommodate to these changes and live their life and kind of reconnect with life in new ways, then they're at risk of developing depression. So clinical depression is actually a disorder of the brain. So it's not a temporary feeling that you have that comes over and then you're able to come out of it. You're stuck in the state, and it really affects you at a fundamental level. So it's hard to get out of bed. You have to push yourself to do basic things like eat or have a shower. You have to force yourself to pick up the phone when someone calls because you really feel no need to connect, or you can't bear the thought of putting that effort to connect. So the symptoms are more pervasive, more profound, they're persistent. There are specific features of geriatric depression, so depression that happens later in life, that can make it more severe. So it's more likely to happen with psychotic symptoms, which is a marker of severity. It can happen with medical illness, so things like stroke, Parkinson's disease, dementia, and often it's hard to differentiate what symptoms come from where, and the depression can be overlooked, but actually it can impact recovery or it can impact functioning.
So on an individual level, what can I do to decrease my chances of developing depression, or if I have depression, on keeping going and sort of making my way through it? What would you suggest?
We need to understand what causes depression in order to figure out how we can prevent it or how to treat it, or how to develop some resilience to it. So again, the depression is a brain disorder. So there's a biological insult to the brain that can contribute to the overall syndrome. And so we have to look at what are the factors, biological factors, that can precipitate or cause depression. So if someone has a biological risk for depression, so family history or high genetic risk, then they're more likely to get it, and that's not a factor that can be changed. If someone has had depression in the past, they're more likely to have it in the future. So kind of preparing in terms of doing therapy and learning skills to cope with stress can be very helpful. Medical illnesses can cause depression. So if someone had a stroke, it's important to be attentive to the possibility of developing depression after, and work with them around social support, coping with the illness, having a chance to talk about their experience of illness as a way of helping promote resilience. Grief, sustained anxiety, substance use, this can also kind of get the brain stuck in certain patterns and lead to depression. And as one ages, there's the higher risk of developing medical illnesses or living with diabetes and high blood pressure and chronic illnesses and pain that can make the brain more vulnerable. So to support the brain biologically so that it doesn't get depressed, or to help with recovery, things that improve brain health. So the general advice: physical activity, good nutrition, good sleep, learning to cope with stress well. These things can be very helpful. Social connection, very important. Even if you're not sure if this is depression, if you struggle, go and talk to your family doctor or whoever you go to talk to when you have this kind of struggles. the family doctor or nurse practitioner, wherever you get primary care, they have resources both to rule out other problems, physical problems that may contribute, and also initiate some counseling, offer medications, or refer to other sources of help. And they also keep an eye on you. They'll monitor how you're doing over time so that if things get worse, you're not alone, you have a backup.
What are some non-medical or non-medication interventions that can happen?
Watching over the lifestyle is very important. So good sleep hygiene, because sleep can get very dysregulated in depression, physical activity, getting out of the house. So finding ways in the pandemic to still maintain these routines without the help of schedules and social activity. So making these behavior plans, simple plans, can make a difference. Connecting socially. So again, figuring out a plan where you have that meaningful connection with others. And this can also be group therapy or one-on-one therapy done virtually. A lot of senior patients that I have are now on the internet, and they're very good at connecting online and doing things online. And those who cannot, there's availability of phone counseling and phone support as well. So reaching out to others to reduce that isolation that comes from being stuck in your home. And then there are therapies that have evidence for depression, and they're very effective. And the type of therapy depends on how your depression presents. But their focus is to help behaviorally. So the idea is that if you start doing things, then you start feeling better. Or they can target thoughts. So cognitive behavior therapy would change how you think of things, and that can change how you feel. Or problem-solving therapy, where you learn coping skills to solve problems, and by solving problems, you reduce the stressors that are precipitating or maintaining your depression. And then things like mindfulness therapy helps you learn how to relax, how to deal with difficult feelings, how to be in the moment. So there's a number of options that have good evidence for treating depression.
Assuming that we've tried these different interventions and lifestyle interventions that you've told us about, and also potentially therapies, and we're still finding our older adult that we love is struggling, what next? What else can be done?
We're lucky to have medications that are helpful, very helpful in depression. And especially if the depression is moderate or severe, medications are recommended, and combining them with therapy can make the whole treatment even more effective. And the most common class of medications are antidepressants. There's a number of types of antidepressants available. And also some other type of medications that can target certain symptoms, like, for example, insomnia or poor appetite. So it's really important to consider that option and discuss with the doctor what are the pros and cons. And for someone who's older, even with certain frailty and other medical conditions, then medical supervision becomes very important to making sure that there's no harm coming from the medications, or that harm is mitigated. And in certain cases, when therapies don't work, medications don't work, or there are other considerations, like someone being very suicidal or not eating, not drinking, it takes time for the medications to work. So we also have neurostimulation techniques or interventions available. ECT, electroconvulsive therapy, although it has a bad press, it's done in a much safer way these days, and it's extremely effective. It's one of the most effective treatments we have for depression, and it saves lives. So it's good to have that discussion with the doctor and read and get informed about ECT, and not write it off right away because of the bad press. And there's also neurostimulation techniques that are non-invasive. So transmagnetic stimulation, for example, that are novel, and there's still research for seniors, but the evidence for a regular kind of before age 65 adults, the evidence is is good.
What can I, as a caregiver, do to make a difference in helping an older adult who's fighting depression and struggling?
Learning more about depression, about the symptoms, can be helpful. And this can be done either through reading, going online, or talking to the doctor of the care recipient, and that you can learn a lot from there. Um, there's a lot of worry as a caregiver. Will my family member get better? Is this forever? Or they're suffering so much, is there nothing I can do? So a lot of worry. The things that are very helpful, that may not feel like that in the moment, but they're very helpful for the person with depression, is to actually be there, to acknowledge their suffering, to be supportive without putting pressure on them to, go and do this, or you got to get out of this depression, or, you didn't go out today. So there's enough judgment that goes with the depression, and you don't want to add to that. But being supportive, saying I'm here, and listening can make a big difference, because depression is very isolating, alienating. And so knowing that someone actually sees you and hears your pain can make a big difference. So it's important to, again, get educated about the risk, learn what are the red flags, talk to the care provider for this person. So you're in the loop, you're in the treatment team, and have a safety plan. So if I notice this or this or this, my plan is to call the doctor. And if I notice this and this and this, my plan is to call 911. Or I'm going to talk to the person I care about. I'm going to talk to them first and ask them these questions.
What are some of the red flags you talk about? What do I need to be watching in case my loved one is suicidal? What should I be looking for?
That's a good question. So knowing the person is very important. So are they someone who are open and talk about things, or are they secretive and guarded and not sharing much? Because that your threshold for worry changes. And have they ever harmed themselves, or have they ever had a suicide attempt, that it can increase the risk? So it's important to know that part of the history. But things to watch for is if they start talking about wanting to die, life not having meaning, talking about suicide openly. And it's okay to ask someone about suicide. You're not going to bring those thoughts in their mind. If it's actually okay to talk, and it reduces the stigma and helps them actually be open about it if those thoughts come to their mind. If there's an abrupt change, especially with treatment, when they start becoming more energized, but their mood and thinking is still depressed. So if there's this big shift where they all of a sudden look like they're fine and they engage but superficial, you got to worry about, have they made up their mind? Right? And now they have that energy, and that's a period of risk. So checking in with the doctor that's treating, it's important. If the person doesn't sleep well, so a lot of insomnia, agitation, anxiety, pacing, a lot of inner turmoil that you're noticing. So angst, it's important to again, kind of be in the loop with the treating physician, whether this is a risk or not.
If I do see a red flag, what's my next step? Where do I go? I find out that they say, yes, I'm thinking of committing suicide.
So if they're saying I'm thinking of dying, or I want to take my life, but it's not something they want to do now, it's kind of a thought, right? Then you're saying, let's talk about this with, and you have to know who the doctor is that you're talking to. Or if there is no doctor involved directly, maybe a crisis line, right? So he or she is in touch with someone that can do some assessment. Or you can say, let's go to the hospital together. So you go to the emergency department together, and they can access a psychiatric assessment, and you have some expert eyes, right, doing an assessment. So someone saying that they want to die, or they want to die by suicide, it doesn't necessarily mean that they will do it. And so allowing them the room to express these feelings and thoughts is important. If someone looks like either they're very agitated, anxious, or they've made up their mind, and they say, yes, I have the pills in the room and I'm going to take them, then call 911 and don't leave them alone, right? And you can tell them, I'm doing this because I'm very worried about you, and it's for your safety. It's not in any way me trying to punish you, or, right? Just be safe.
Thank you so much for your time today and for walking us through these important issues. We really appreciate it.
You're welcome.